Hey guys, how are all of you doing? Now today we are here with another important video that is going to cover the very important topic and can't miss topic for INI-CET November. So here we go. So we're done with NEET PG 2025. Are you satisfied? If yes, then a lot of congratulations to all of you. And if no, our next focus is going to be INI-CET November. Okay, so introducing myself here, I'm Dr. Pragya Khatri, and we are going to do quick 5 questions here today with a very important topic that is 99% of expected in INI-CET November. So we are just going to cover this topic with the most important questions associated with it. So here we go without further ado or delay. So this is our first question. Okay, so a 2-year-old term male neonate is brought with yellowish discoloration of the skin. The baby is born by normal vaginal delivery and cried immediately and is exclusively breastfed. The examination shows jaundice up to the face and chest, and the baby is active with no lethargy, no hepatosplenomegaly, and the serum bilirubin is 10 mg per dl, which is unconjugated. So first of all, we have given in the question that the bilirubin is unconjugated, so all the diseases associated with the conjugated ones would be ruled out. But since we can see here no disease with the conjugated one we have been given it, so it is completely of no use here. Now the history says that the term that the neonate is 2-day-old term male. So we know that the physiological jaundice takes place within 24 hours. No, it takes place after 24 hours. Yeah, if it would have been within 24 hours, then it would have been pathological jaundice. Now the hemolytic disease of your newborn is not it could not be that, because it is associated with no hepatosplenomegaly, no lethargy, no danger signs or red flags have been present here. So we can rule out very easily this hemolytic disease of newborn. Now we can see in the history the 2-day-old term male neonate is brought with yellowish discoloration of the skin, and the baby was born by normal vaginal delivery, cried immediately, and is exclusively breastfed. The examination shows jaundice up to the face and chest. The baby is active with no lethargy or no hepatosplenomegaly. So we know that the breastfeeding jaundice is something which presents early within 2 to 5 days, and breast milk jaundice is which is present a little late, that is 5 to 7 days, and is persists for a week. And here the next step would be to continue breastfeeding. Okay, and now the early presenting is your breastfeeding jaundice, where the baby presents with dehydration. It is due to the inadequate feeding. It happens due to the inadequate feeding, and the main reason for breast milk jaundice is because of the beta glucuronidase, which is present in the breast milk, which prevents conjugation of the bilirubin. So unconjugated fraction of the bilirubin increases in breast milk jaundice. So in breastfeeding jaundice you can see that the baby presents with dehydration, and it is the unconjugated inadequate breastfeeding. So here we advise frequent feeds. So here we can see in the question is time that the baby is active, yani ki baby is not dehydrated, and there is no lethargy present in the baby. So breastfeeding jaundice would be ruled out because the baby is not dehydrated. Breast milk jaundice would also be ruled out, and since it is present in the after 24 hours of delivery, and it is associated with no danger signs, so that is why it would be physiological jaundice. Also we can see the range of the bilirubin. The range of the bilirubin has to be more than 12 if it was pathological jaundice, so it is less than 12 here, that is 10. So it definitely pointing towards the physiological jaundice mode. So this is your answer here. Now moving on to the next question, that is a 2-day-old preterm. Now here the history is giving us the preterm baby develops jaundice. Total serum bilirubin is 14 mg per dl, predominantly unconjugated. The baby is lethargic with poor feeding, high pitched cry. On examination there is opisthotonus and abnormal posturing. Now, all of this is very clearly indicating to the red flags and the danger signs that we get here when it is pathological jaundice. Now, since the baby is preterm baby, there are more chances of pathological jaundice and kernicterus which could develop because the unconjugated bilirubin crosses the blood-brain barrier and gets deposited into the globus pallidus. But here we have to see the other options also, and we have to rule out other options also. So if it was neonatal jaundice, then it would have been a case of conjugated bilirubin. So we can rule out neonatal jaundice. Now, Johnson syndrome also present with conjugated bilirubin and hepatomegaly. So this is ruled out here. Now, your biliary atresia is also a case of conjugated bilirubin. So these three options can be very easily ruled out, and A would be your answer here. But for further seeing this question ahead, I want to be very clear with all of the points. We are going to cover all the points here. So when the baby is the preterm baby is presenting with unconjugated hyperbilirubinemia, now this unconjugated bilirubin crosses the blood-brain barrier and gets deposited into the globus pallidus, which causes kernicterus, which is the most common complication, most threaded complication, which can occur if there is no phototherapy or no exchange transfusion happening in time. So the exchange, if you don't carry out with exchange transfusion or phototherapy, this could be the complication that could occur. Now, in your chronic kernicterus, there could be a risk of sensory neural hearing loss, and then your chorioathetoid cerebral palsy. So chorioathetoid cerebral palsy can also occur here, and it can lead to the death of the neonate. So this is the whole thing that we'll cover here about kernicterus. So we have to prevent kernicterus from happening. So if we don't do any intervention on time, then it could lead to kernicterus, which could further lead to death, and it is a very threatened and dangerous sign. Now, moving on to the third question, a 1-day-old term male develops jaundice within 12 hours of birth. So this is within 12 hours of birth, and we know that physiological jaundice is after 24 hours. So definitely it is not physiological jaundice, it is pointing towards pathological jaundice because it is happening within 12 hours of birth. Now the baby is irritable, has pallor and hepatosplenomegaly. The mother is O negative and the baby is B positive. Now, the peripheral smear shows anisopoikilocytosis, spherocytes, and reticulocytosis. Now, what happens is when the peripheral smear is showing you spherocytes and anisopoikilocytosis, it is giving you the picture of hemolytic anemia. It is giving you the picture of hemolytic anemia. So, this cannot be physiological jaundice because it is happening within 24 hours. So it is definitely not physiological jaundice, it is pathological jaundice. So we can rule out physiological jaundice here. Now, G6PD deficiency, the G6PD deficiency doesn't take place in a neonate, in a 1-day-old neonate. It won't take place because it needs some sort of a stress, okay, some oxidative stress or any a history of fava beans or primaquine or anti-malarial drugs is all that we know about it, and some oxidative strain or some fever or some illness is required for it to take place. So this is not given in the history, and it definitely doesn't take place in a neonate. So this is rule out. Your option D is rule out. Now we have two options which are very close ones, that is the ABO compatibility or RH hemolytic disease. Now what happens is the mother is O negative here and the baby is B positive. So the RH factor is more important than the ABO one. So we'll go with option C here because the ABO incompatibility is the milder form, and it could also take place with the first pregnancy, and it is milder. But your RH hemolytic disease is like not a very mild form of this disease, and it always takes place after the first pregnancy, and it is associated with pallor and jaundice and all these hemolytic picture that is given here. So we'll go with option C here. Okay, so then moving on to the next question, that is your day 7 old neonate presents with persistent jaundice On examination, the baby is active, thriving, and exclusively breastfed. Now, the total bilirubin is 12 mg per dl, and the unconjugated fraction is predominant. No hepatosplenomegaly, no pallor. Now, first of all, we are talking about how we are going to rule out the options. So, first we'll rule out the options. Now, here the question is telling us that the unconjugated fraction is predominant. यानी कि unconjugated वाला ज़्यादा है. Conjugated वाली conditions we'll rule out here. So we'll rule out biliary atresia, which is a conjugated one. Then your neonatal sepsis is obviously unconjugated, but the hepatosplenomegaly and pallor are not seen here. So that's why the danger signs are not included in the clinical stem here. So the neonatal sepsis would be ruled out. Now your breast milk jaundice and Crigler-Najjar one. Now the baby is active and thriving and exclusively breastfed is ruled out by rules out Crigler-Najjar syndrome, because Crigler-Najjar is a rare condition and it doesn't it involves some danger signs. Okay, it is involving some danger signs, and it wouldn't present the baby with active, thriving, and exclusively breastfed. Since the baby is exclusively breastfed and it is a late presentation, that is from day 5 to day 7, and it persists till weeks, and it is due to the beta glucuronidase that is present in the milk, that the unconjugated fraction of the bilirubin is increasing here. So here our next step is continue breastfeeding. Next step is continue breastfeeding. Since the baby is thriving and is active and is exclusively breastfed, Crigler-Najjar would be ruled out, because it can also lead to connectors and other like severe conditions, which is not given in the question. So this is ruled out, and A is your answer here. Okay, so then moving to our next and the last question, that the 3-week-old infant is brought with jaundice since 10 days. The baby, and so it is it shows a long duration. The 10 days is a long duration, and the baby is like 3-week old. So 3 week is like something that is taking place later in the life. Okay, now the baby has dark urine, pale clay colored stools, and hepatomegaly. The hepatomegaly is also associated here. Now the serum bilirubin total 15 mg per dl, direct is 12. So direct is 12, the direct fraction of the bilirubin is 12, so the indirect one would be 3. So direct is predominating here. Okay, so now what else do we have here? Now the question says that the ultrasound shows absent gallbladder. So the absent gallbladder is associated with biliary atresia only, because if it was like neonatal hepatitis, then the gallbladder would not have been absent, and then same for both these. But all these conditions are associated with conjugated bilirubinemia only. So this is how we can come to the conclusion, because the gallbladder absent on ultrasound is like very classical for biliary atresia. So this is how we're going to solve all these questions related to neonatal jaundice, which is a very, very important topic for both NEET and INI-CET. So we covered it here in a like much clinical and which could be asked like expected kind of a thing, which which covers your clinical stems and all the things that are important here in this topics, majorly covering all the vignettes, like the physiological jaundice takes place after 24 hours, and your pathological jaundice takes place within 24 hours, and your danger signs, okay, pathological, physiological, danger signs, then your connectors, and then your what else, breast milk and breastfeeding. First, earlier presenting is breastfeeding due to inadequate feeding, and then your breast milk because of the presence of beta glucuronidase. Okay, so then your breast milk. Then a very important question that is asked is your connectors. that where in which part of brain is it deposit. So it is globus pallidus. The answer that you have to give is globus pallidus. Okay, so these are the, and your values. Okay, so more than, if it is more than 12 in a term, and if it is more than 15 in preterm, then it would be pathological. Okay, so all these things. And then your danger would be more than 0.5 mg per dl per hour if it is increasing, and or more than 5 mg per dl per day, then it would be dangerous and pathological. So this is all the things that are important, and we have covered it very successfully in our video. So this is all that we have for the day. Thank you and have a nice day, and stay tuned and do subscribe if you want more further such topics which are important for the exam and you don't want to miss them. So click your bell icons to get all our notifications, and subscribe and stay tuned for further updates. Thank you and have a nice day.